and this is I find that in Jharkhand areas, can we use an insulin storage device from RSSDI? And sometimes even the exercise doing, what we are telling your patient, go and do exercise. Do we need to teach such persons? What are the exercise types? This is aerobic is important or resistance is, they are already doing that. Even that these entities are not diabetic gestures. They are dancing other things. And all then you go for the all Jocelyn course, the diabetics who knows the most, lives the longest. And it is better to discuss how far you have walked than how little you have eaten. And well-trained nurse is of more value than a patient doctor, remember. So these are how things are changing. So what has not changed from bending solution to the time in range is the 225 vision of longevity for diabetics. I'm not going details, but this is a very, very exciting field to discuss how the sleep, the circadian rhythm, the sunlight exposure, the nature and social connection, even the grounding, personalized diet, vegetables, using genetic data, exercise regimes, meditation, mindfulness, lots of things are happening. And whole problem is what? You are taking more and more food, and you are not expanding that, not going to burn that, and then there are oversupply and the undersupply. This is the main reason of problem in today in diabetes. I will end here with that. Think also about the endocrine disruptors, then increase the telomerase, then the gut microbiota, and always show this slide to your school children that how these diabetic superfoods can protect, and we are not propagating this one, how the physical activity can do, what Surya Namaskara can do, and other things. With last slide, that precision diabetes based on genetic testing is a new concept for diabetologists. Genetics is not a part of routine clinical training at present. Traditionally, the specialty of diabetes emphasizes a best treatment rather than diagnosis, and so with that, precision message in diabetes is very, very important. And thank you very much that this was a disclosure from the ADA. If we do not know what causes type 1 diabetes, and we do not know at present what causes type 2 diabetes. Thank you very much. Thank you for inviting me. Thank you.
Thank you, Peg. How diabetes care has evolved over the years from Benedict solution to precision medicine. And I particularly like that one slide which you projected when you stressed upon the importance of understanding precision medicine, that 80% of our treatment is going as waste.
Yeah.
And how we have to move towards precision and personalized medicine to correct ourselves. Thank you for that excellent lecture, sir. So we'd like to join you on the stage. And next, we'll have discussion at the end of the session. Next, I would like to call upon our senior physician from Chennai, Dr. S.S. Lakshmanan, sir, who is a senior consultant physician, a very knowledgeable academician, and with more than 5 decades of clinical practice. He has been there in all academic forums to teach us about how on the topic case-based discussion on young diabetes. So over to you, Dr. Lakshman, sir.
Thank you, Dr. Dharmarajan. I present a very, very nice case, very interesting case of a very, very young fellow diabetic. I treated about 1 month back. He's a 13-year-old school student. He's a pure vegetarian Marwadi boy, was admitted with a high fever, abdominal pain, continuous vomiting of 3 days duration. He is a known case of type 1 diabetes on basal bolus insulin for the past 2 years. He was evaluated for abdominal pain in the year 2023, and he was found to have a hydronephrosis of the left kidney with elevated blood sugar of more than 600 in a corporate hospital. So they shifted the patient to a diabetes specialty hospital for sugar control before surgery. He was treated with insulin therapy and was investigated and diagnosed there as a type 1 diabetes. The previous hospital 2023, the A1C on admission was 17.5%, and the fasting C-peptide was negligible. The postprandial stimulation has just give 0.2 picomoles of C-peptide. GAD antibody was negative in the hospital where he was treated on the year 2023. The diagnosis made in the hospital was the diabetic ketosis with type 1 diabetes. He was started on basal bolus insulin of the insulin R 15 units 3 times a day and 25 units of the glargine insulin at bedtime. After 5 days, it was not sufficient. The insulin was escalated to 18, 20, 18 of short-acting insulin and the 25 of the glargine insulin. He made him fit for surgery. He went back to the corporate hospital where he underwent a left kidney pyeloplasty with the basal bolus insulin coverage and was stented. The stent came out within 3 months' time. The repeat stenting was done after 3 months again. Now, after 2 years, he presented to my hospital with a diabetic ketoacidosis with a severe urosepsis. He was febrile, toxic, he was extremely dehydrated, the pulse was 132, respiratory rate was slightly hurried. Very, very lean boy. He was BMI was less than 18, weight was 36 kg. Abdomen showed a severe left loin tenderness, no markers of insulin resistance. He has given a history, the operator for left congenital hydronephrosis and DJ stented 2 years back. There is no family history of diabetes. Random sugar was 620, A1C was 16.8. Urine were densely have ketones with a lot of pus cells and RBCs. His USCR was positive, urea was 56, creatinine 1.4. He had hyponatremia of 128, sodium, potassium was 5.4 and chloride 98. LFT was normal. You can see the sepsis, the total count was 32,000 with a polymass of 84 and the CRP was 130 milligrams. Chest was normal, EC showed a tachycardia, echo is no LV dysfunction. Scan abdomen showed a residual hydronephrosis left kidney with a severe perinephric fat standing, suggesting acute pyelonephritis. Serum hydroxybutyrate was positive. The diagnosis was diabetic ketosis with the UTI, with the pyelonephritis, with the type 1 diabetes. Shifted to ICCU. He needed, we started on IV insulin therapy. He needed about 5 to 8 units of IV insulin every hour to almost 150 units per day to keep the blood sugar less than 180. Given meropenem, saline, standard care for diabetes ketosis in ICU, the RFT became normal in 3 days' time. After shifting to the ward, he needed the 5-ASP insulin, the very short-acting insulin, 18 units 3 times a day, and the Tresiba, the Degludec insulin at 30 units at bedtime, just to keep the blood sugar between 180 to 240. He was advised insulin pump by me. The parents were not willing. It was very difficult to control the blood sugar with the below 180 milligrams. Now the problems in hand is that the patient has got a sugar of more than 600 4 times, diabetic ketosis 3 times, pyeloplasty left kidney once, DJ stenting was twice, recurrent UTI. He needed a very large dose of insulin, still the sugar not under control. Very pathetic looking boy, BMI of 18, weight of 36. The pump is the only solution. Are we missing the diagnosis or the both sides of the metro train looks similar? After 1 month, I again wanted to check the GAD antibodies and the C-peptide levels. Again, the GAD antibody was negative. Probably it belongs to a non-GAD antibody positive type 1 diabetes. C-peptide, again, the fasting was 0.3 nanogram and the stimulated was 0.8 nanogram. I don't, there is stimulus that the beta cells have, some living beta cells. We are puzzled, unsure, is a whole family were reluctant to get the patient on insulin, so much of insulin. I went back to the classification of type 1 diabetes. whether we have the same type 1 diabetes or different type 1. We have this boy, classically looking, ketosis prone, malnourished boy, type 2 diabetes. We know the specific types of diabetes. I have had shown you last, I think, presentation, a young fellow who was treated for 3 years as a type 2 diabetes. On the 4th year, we found out the boy had a Cushing syndrome. So please see that the secondary types of diabetes not to be ruled out by any means. It's not a GDM. There's a condition called type 5 diabetes. I was attending the Bangkok IDF April 8th, 2025. They reported a first case in 1955, BMI less than 19, very high blood glucose. They always need insulin, but usually they don't develop ketonuria, in contrast to my case. So whether my case belongs to a type 5 diabetes. This is a type 5 diabetes. I sent the sample of the boy, informing the parents that I'm trying my level best for a very precision diagnosis, and I waited for 8 weeks. The results came. Anyone want to discuss this case before I disclose the diagnosis? Chairman, audience. I think some of you would have heard this case before. Okay, I presented once or twice in a forum. Why? Yeah, I think there's a good diagnosis. I think the results came. The results came after 2 months. It took 8 weeks for the genetic studies to make a diagnosis. Dr. Mohan wrote a letter, congratulations on picking a case of HNF beta MODY, the MODY 5. The MODY 5. But they cautioned me that the MODY 5 is exactly like type 1 diabetes. Most of them require insulin. The Tattersall-Pajan's criteria, the one which gave a clue that there are 3 generations of people with the diabetes in the family, early onset, non-insulin dependence, absence of obesity, and they classically given absence of diabetic ketoacidosis. Probably the time where they had a Bajans and Tattersall, there were only type 2 and type 3, the MODY type 2, type 3. They do not go for the ketoacidosis. That was the one MODY 5. As you could see here, the defect is in the HNF1 beta and the severe kidney disease, pancreatic hyperplasia, and any female genital organ abnormalities. I think the message is very clear to you. Somebody presents with a type 1 diabetes like picture with a renal abnormality. That's the one. The organ which is affected is kidney. More than 90%. Please think of MODY 5. The common MODY, what you get in your practice is the MODY 3 and MODY 2. MODY 2 is the glucokinase deficiency. HNF-A deficiency is the MODY 3. Of course, the syndrome is called the RCAD syndrome. I think there was a mention on the floor that whenever you have a renal cyst or and diabetes, it's called the RCAD syndrome. That's the gene which is carrying that MODY 5. 17q, which is the focus. This is called monogenic diabetes. MODY 5, the HNF beta gene and the chromosome 17q. The first case was actually reported in the 1997 in the Japanese family. HNF1 beta is encoded by the human transcription factor 2 gene. And this variety of organs it is expressed, including the kidney, pancreas, genital. That's why they are always present with an abnormality of an other organ, either a kidney or a genitourinary system. And the maturity onset of diabetes, now we have the 15 subtypes. There are 14, I think 15 was reported by Dr. Mohan, among which the MODY 5 accounts less than 5%, and it has got number of extra pancreatic manifestations. Type 1 diabetes, and Modi share similarities in the early onset, potential for misdiagnosis